This was a meeting with the CDC, or conducted by the CDC rather, regarding hepatitis B vaccines. Now, this is a CDC vaccine meeting. It's a federal vaccine advisory committee, and they're discussing whether newborns should still get the hepatitis B vaccine. Now, since 1991, the recommendation is that all babies be vaccinated against the liver infection, that's hepatitis B, within 24 hours of birth. The second dose between 1 and 2 months, the third dose between 6 and 8 months. Now, this advisory committee will be led by Health and Human Services Secretary Robert F. Kennedy Jr. for this meeting today. During a Senate hearing in June, physician Senator Bill Cassidy said before the 1991 recommendation, as many as 20,000 babies contracted Hep B from their mothers in utero or during birth every year. That's compared to today, when fewer than 20 babies every year get Hep B from their mother. So let's listen in on the recording of the CDC Advisory Committee meeting on the hepatitis B vaccine right now.
Thank you, Mina. So I'd like to read an opening statement today. Good morning. My name is Dr. Robert Malone. I'll be serving as your meeting chairperson over the next 2 days. I want to start by thanking all ACIP members, working group members, and support staff for being here and for the work you've been doing in preparation for this week's meeting. I know it's not been trivial. This is my third meeting since beginning service as an ACIP member, and it's an honor to open this meeting today. We have a full schedule over the next 2 days, and before we start, I wish to highlight and specifically thank the members of the Hepatitis B Vaccine and Childhood Vaccine Schedule working groups operating under the leadership of Dr. Vicki Pebsworth, particularly those that freely shared expertise and advice relating to hepatitis B vaccines, adjuvants, and related clinical and public health policies. The work we have done to prepare for today relies upon internal work group discussions, but form the basis for what will be discussed and the recommendations we will make to the CDC Acting Director. Dr. Martin Koldorf, our guide for the previous 2 meetings, has now moved up from the ACIP to serve inside the HHS as a key advisor to the Secretary, and Dr. Kirk Milhound, who was first introduced at the last meeting, will now serve as chairperson. Speaking personally, I have known Kirk, as well as his amazing wife, Dr. Kim Milhound, for a few years now, and when asked, I endorsed his appointment without reservation. So please join me in welcoming Dr. Kirk Milhound as the next chairperson of the ACIP. He is eminently qualified. I'll be serving as chairperson for this initial meeting under his guidance, as Kirk is attending virtually, as you know. According to the ACIP charter, the main duty of the vice chair is to serve as interim chairperson when the appointed chair is not able to attend the meeting in person. I can assure you that Kirk has been very active in providing leadership since his appointment while maintaining his busy clinical practice as a pediatrician and pediatric cardiologist. I want to formally open this meeting by acknowledging the principles that must guide ACIP's work. These are key: evidence, transparency, and a willingness to look critically at the data before us to ensure that the recommendations we make are grounded in evidence-based science and best medical practices. The primary mission of the ACIP committee is to provide independent advice, I underscore independent, to the CDC director. Our responsibility when developing advice is to evaluate the totality of the evidence as it exists today, with scientific rigor, intellectual honesty, and courage, to ask and answer the hard questions. Once we reach a majority opinion, we're also tasked with clearly communicating our advice and reasoning to both of our key clients, 2 key clients, I want to emphasize, the CDC director and the American public. Many of you will recall that in September, ACIP deferred a vote on proposed changes to the hepatitis B vaccination schedule. That decision was not about hesitation or reluctance. It was about standards. Several data elements the committee requested were incomplete, and the evidence did not yet meet the level of clarity required for a confident, evidence-based recommendation. When gaps in the evidence emerge, the responsible action is not to push forward. It's to pause, review, ensure that we fully understand what the data can and cannot support, and then formulate independent advice to the CDC director. This is our charter. Since that meeting, CDC formed a dedicated hepatitis B work group to examine the outstanding issues in greater depth. That group has been working diligently, I can attest to that. Many hours have been invested since then in preparation for this meeting. By the way, I'm not able to disclose the nuance of that work group, but it is quite diverse in membership and represents a full spectrum of opinion regarding hepatitis B vaccination. Their work has helped sharpen the questions we need to answer and improve the quality of the discussion we will have today. I want to emphasize this is exactly how the scientific process is supposed to function. When data are complete, we say so. When additional analysis is needed, we conduct it. When assumptions need to be revisited, we revisit them. We're not here to reach quick conclusions. We're here to reach accurate ones and to provide independent assessment and advice to the director and to the public. Today's agenda reflects the complexity of the issues before us. My hope is that we approach each discussion the same way we approached the COVID-19 vaccine issues in September, with seriousness, clarity, and a willingness to challenge our own prior assumptions. ACIP's credibility depends on our commitment to a deliberative, transparent, evidence-based process. You'll see that in play during the discussions today and tomorrow. Finally, I want to acknowledge in particular the CDC staff and external experts who support this committee. Their technical work, from surveillance to modeling to implementation research, is essential. The ACIP depends on their diligence, and all of the appointed members are grateful for their contributions and for all the contributions of the career staff across HHS, including in our affiliate organizations at FDA and NIH. Thank you again for the work that you do and for the integrity you bring to this process. We have a full agenda today, and I look forward to a thoughtful and productive discussion. Thank you for your time. Now, with that, I now call to the floor Dr. Vicki Pebsworth, who is representing the ACIP Childhood and Adolescent Immunization Schedule Work Group, to discuss the policy context and schedule comparison relating to hepatitis B. Do we have those slides? Take it away.
Good morning. Thank you, everyone. And I'd like to respond to what Dr. Malone said about thanking the CDC staff, because they have been very helpful. We could not have done the work we did without their assistance. So I'd like to begin by just also acknowledging that the Childhood Adolescent Schedule Work Group is the umbrella work group, and there was then a hepatitis B sub-work group formed to deal with the question that was asked of us. And there are 4 of the work group members here present, Dr. Evelyn Griffin, Dr. Kirk Milhone, and Dr. Tracy Beth Hogue were members and served on the work group. So they'll be stepping in and helping to answer the questions that will be coming up. So we were asked to focus on one group, newborn infants born to mothers who test negative for hepatitis B surface antigen during pregnancy, not newborn infants born to mothers who test positive. Thus, we primarily focused on a vaccination dose given at a specific time, the birth dose, the dose given to all newborns within hours of birth. The literature we reviewed mainly involved the 2 U.S. licensed single antigen hepatitis B virus vaccines, not the combination vaccines containing hepatitis B antigen that are given later in infancy. Next slide. This morning's presentation is divided into 3 sections. I will cover the introduction and policy context, and then Dr. Cynthia Neveson will cover the burden of disease and efficacy, followed by Mark Blaxell, who will address the safety portion of the presentation. Next slide. According to the ACIP's charter, vaccines are supposed to be reviewed on a periodic basis. The ACIP Childhood Adolescent Schedule Work Group was tasked with assessing the current recommended schedule, including the use of a universal birth dose of hepatitis B vaccine in children whose mothers test negative for hepatitis B surface antigen at delivery. So why are we here? In addition to needing to review hepatitis B because it had been so long since we had reviewed it, we're doing this because of concerns that have been raised by some groups. The current policy is misaligned relative to existing recommendations in most other developed countries. And again, the prolonged time since the last review per ACIP's charter. Next slide, please. So how did we get to where we are now? Several key events shaped the current landscape. A rapid rise in reported acute U.S. cases of hepatitis B, which is a source of very serious liver disease. Licensure of a plasma-based vaccine in 1981 that targeted high-risk groups. Emergence of new technologies and changes in vaccine-related liability. Evolution of ACIP recommendations during the 1980s. Dissatisfaction with the high-risk groups targeting strategy, which had led to an ambitious new hepatitis B eradication strategy. And lastly, the leap in 1991 to adopt the universal birth dose recommendation. Next slide. This slide shows what was going on with hepatitis B. It shows that over a 25-year period, reported cases jumped from a few thousand to well over 25,000. This happened for two main reasons. First, rising transmission of acute hepatitis B due to bloodborne exposures in high-risk groups. In the 1960s, there was unscreened, blood-infected patients with frequent transfusions, followed by a rise in the 1970s of dialysis-based transmission, and then into the 1980s, there were expanding sexual networks of men having sex with men and higher female-to-male partner counts, along with rising IV drug use and heroin usage expanding outward from urban pockets. Second, at the same time, there was a surge of immigration from high endemicity areas in Southeast Asia after the end of the Vietnam War. 1.5 million refugees from Indochina, which significantly increased the reservoir of chronic disease carriers. Next slide, please. Factors that affected the policy shifts. In response to the hepatitis B crisis in 1981, the FDA approved a new plasma-based vaccine for hepatitis B virus, the first vaccine against hepatitis, and it was judged as highly effective. Concerns emerged about the safety of the donor source material. Only 6 years later, a new vaccine based on a recombinant technology platform, rather than donor plasma, was licensed by the FDA. It was a hepatitis B antigen-based product manufactured in yeast. Concerns about liability for pediatricians and manufacturers about the new recombinant vaccine were removed following the passage of the 1986 National Childhood Vaccine Injury Act. Next slide. So this was the context when an important editorial titled "Worldwide Elimination of Hepatitis B Transmission, We Have the Way, We Have the Will," was published in JAMA in April 1989 by Dr. Hal Morgan and Dr. Donald Francis from the CDC, both of whom are public health leaders. They reasoned that if vaccinations were given universally at birth to infants in populations that have a high rate of perinatal hepatitis B virus transmission, and with childhood immunizations to infants in other parts of the world, a worldwide cohort of persons protected from this long-term infection would be established. And in the United States, selective immunization of groups at risk of infection has not been effective in lowering the overall incidence of the disease, and immunization strategies targeted at both infants and adolescents should be considered if we are to control this disease. This statement typified and created a rationale for opening the door to vaccinating infants who were not at high risk of infection. Next slide, please. This chart shows the evolution of ACIP recommendations. In 1982, only infants of hepatitis B positive mothers were recommended to receive HBIG, the hepatitis B immunoglobulin, at birth and then be vaccinated at 3 months. In 1984, 3 months was changed to 7 days. In 1985, both HBIG and the vaccine were to be given within 12 hours of birth. In 1987, the first recombinant hepatitis B vaccine was licensed. And finally, in 1991, ACIP recommended that all infants, even those born to hepatitis B surface antigen negative mothers, be vaccinated before hospital discharge or no later than 2 months. But 14 years later, in 2005, the 2-month option was removed, and all infants were to be vaccinated within 12 to 24 hours of birth. Next slide, please. So what are we trying to accomplish today? First, we need to address stakeholder and parent dissatisfaction that we have become aware of. Second, we need to report on the work group's review. More on that later today. Third, we need to consider whether there are immunization policies that are better aligned with other countries similar to ours, are based on evidence and support the need of high-risk persons and populations without treating everyone as if they were genetically the same, and explicitly consider public health and vaccination ethics. Next slide. The work group was asked to assess the use of a universal birth dose of hepatitis B vaccine in children whose mothers are hepatitis B surface antigen negative. As noted in the work group's terms of reference document, basically our scope of work, which states that the work group will review the efficacy and safety of the immunization schedule for children and adolescents, identify efficacy and safety problems, and address stakeholder concerns. To that end, in our TOR, 2 Institute of Medicine reports are cited. First, the 2002 report, Multiple Immunizations and Immune Dysfunction, where over 20 years ago, 1/4 of parents expressed concern about the number of immunizations children were receiving and concluded that concern about multiple immunizations has been and continued to be of societal significance in terms of parental worries, potential health burdens, and future challenges for immunization policymaking. Second, in the 2013 report, the Childhood Immunization Schedule and Safety, Stakeholder Concerns, Scientific Evidence, and Future Studies, directs DHHS to incorporate study of the safety of the overall childhood immunization schedule into its processes for setting priorities for research, recognizing stakeholder concerns, and establishing the priorities on basis of epidemiological evidence, biological plausibility, and feasibility. Next slide, please. As it relates to stakeholder concern, the work group reviewed the literature and identified 2 relevant surveys that we'd like to comment on now. First, there was a 2014 survey of Oregon parents, and this is a survey of hospitalized just after birth newborns. 5% of parents in that survey refused the hepatitis B birth dose. 8% wanted to wait. 6% were undecided. The reasons why they gave for these preferences were that 78.1% thought that the baby was too young, 70% discussed vaccine safety concerns, 43.8% said the baby was at low risk of infection. Another more recent survey conducted by the Kaiser Family Foundation and the Washington Post of parental attitudes about vaccines found, this was just in October, found that 13% had skipped or delayed the hepatitis B vaccine, 16% had skipped or delayed other vaccines, and the reasons for doing so were they were concerned about side effects. 53% had doubts about safety, 51% said that vaccines were not necessary, 42% were not wanting multiple shots, 35% said safety testing was lacking, and 26% said CDC recommends too many vaccines. 41% wanted to space out the shots, and 58% said little or no confidence in the federal agencies. Next slide, please.
Okay, so that was a look at the CDC's advisory committee meeting on hepatitis B vaccines. Now, we know that was in the weeds, right? I mean, they are really getting into a lot of the nitty-gritty, including surveys of parents and policies throughout the years and how that has impacted the spread of hepatitis B. We know that is detailed and that it is, again, very in-depth, but with it being such a hot button topic and with it being something that continues to receive scrutiny here in the United States, we want to make sure that we're touching on those things and we're listening in, and we hope that it is productive and informative. We do know from NPR a report that delaying the birth dose of hepatitis by just 2 months could result in at least 1,400 additional preventable cases of hepatitis B for each year that the revised recommendation is in place. Now, that's according to new analysis. Delaying the vaccine until age 12 could result in at least 2,700 preventable infections each year, according to that same analysis. That is a report from NPR.org.